is just around the corner. We're going to review the anatomy and physiology because you really need to know it and understand it so you can explain it to patients. Okay, so you already know what the endocrine system is. It's a network of glands and organs, and it works on a negative feedback system. So anytime somebody has an endocrine disorder, that means that the feedback system is not working, which is fine. We're not going to get into much detail with that. For the posterior pituitary, remember that ADH is secreted from the posterior pituitary. So if somebody has their pituitary removed, they're going to need lifetime hormone replacement with ADH. Growth hormone results in acromegaly for adults, giantism for kids, but we're an adult med-surg course. So they do not increase in height if they have acromegaly. However, all their organs grow big and wide, which is why they have a lot of health issues. The thyroid gland is a butterfly-shaped gland right on your throat and under in your neck, I should say. And then if you look at the back of the thyroid gland, and this is important for you to know, there are the parathyroid glands. And if somebody has a thyroidectomy, the provider or surgeon is going to inadvertently, most likely, take out these parathyroid glands. Parathyroid hormone helps us with calcium. So if you have too much, in other words, hyperparathyroid hormone, the patient is going to have hypercalcemia. If they have hypoparathyroid hormone, then they are going to have low calcium levels. So if you take the parathyroid glands out, the patient is going to suffer from low calcium levels. You need to know the difference between high and low calcium, and we'll talk about it later. The thyroid hormones. There are 3 hormones secreted from the thyroid gland. They increase the metabolic rate. That's like the job of the thyroid gland to work on metabolism. And if we have too much thyroid hormones, in other words, the patient has hyperthyroidism, they're going to have a high T3 and T4. And that makes sense because we're talking about hyperthyroidism. So they have too much of the hormone, and they'll have a low TSH. If they have hypothyroidism, they're going to have low T3 and T4 and have a high TSH. All right, the next hormone that the thyroid secretes is called calcitonin. All you have to do is take this L for lower and Ca for calcium. Calcitonin lowers calcium. So it opposes PTH, which if you take the H, it higher calcium. I know that's not correct English, but it's an easy way to remember it. All right, so parathyroid hormone, we talked about, it regulates calcium and phosphorus. Let me tell you what students get confused about. You know that calcium and phosphorus live in an inverse relationship. In other words, if somebody has high calcium, they'll have low phosphorus. What students get mixed up is they get phosphorus mixed up with parathyroid. I don't know why, but they do. So just make sure you keep that straight. If you have hyperparathyroidism, you're going to have high calcium, low phosphorus. Okay. The adrenal gland, you're going to need to know which hormones are secreted from the cortex versus the medulla. Okay, so in the adrenal medulla, we have the catecholamines, and in the cortex, we have sugar, salt, and sex hormones. The pancreas, we're going to get into more detail for the next exam. Now we're going to go to the actual disorders themselves. So acromegaly, we talked about, was a problem with too much growth hormone. They're going to have coarse facial features. They'll have that lower jaw that sticks out, caveman forehead. They have no height increase. We talked about that. They're going to get hypertension, carpal tunnel syndrome, diabetes, because all their organs are enlarged. The treatment could be radiation treatment to the brain, hypophyseectomy, octreotide, or bromocriptine. Remember, bromocriptine, we have to worry about postural hypotension, and also clear nasal drainage. And you know you're going to test that for halo sign. SIADH can happen for a number of reasons, right? So the patient could have TBI, could have brain surgery. Lung infections also can trigger SIADH, lung tumors, lung cancer, and certain drugs. Okay, so remember, it's secreted by the posterior pituitary. Patients are soaked inside. And this is what students get mixed up. They have a high specific gravity and a low sodium. So you are very worried about the low sodium because that is a major safety issue and your patient can seize and die. So you need to mitigate that. And they're going to be at risk for pulmonary edema, which, as you know, can also be deadly. Okay. So the signs and symptoms are usually due to the low sodium level. So they could have seizures, anorexia, irritability. They're going to gain weight. Their LOC can be decreased. Urine output's decreased as well because they're holding on to all the water. High specific gravity and a headache because of the hyponatremia. So the first line of treatment is going to be non-invasive. And it's about stopping free water. So they'll be on a fluid restriction. If they have a PEG tube and G tube and they're being fed, instead of irrigating with water, you're going to irrigate with normal saline to put saline back into their body. You're going to liberalize salt in the diet. So the patient can now eat like soup and chips, and they usually like that. They're going to be put on INO daily weights. You need to assess the neurological system. The drugs are Vaptin drugs, daily weights, and hypertonic saline if needed. We usually don't do that too much. All right, a hypophyseectomy. This can be done for patients that have pituitary adenomas, so cancer. No, it's not really, it's a benign tumor. So the post-op care involves making sure they don't get increased intracranial pressure. So you're going to put the head at bed 30. You're not going to allow them to cough or blow their nose. You need to explain to them they need to mouth breathe and test any drainage for halo or glucose. No bending at the waist, no brushing their teeth because that can increase intracranial pressure. They can floss their teeth. Monitor for meningitis, so that would be a fever, nuchal rigidity, and nasal pad is removed by the surgeon in 2 to 3 days. People that have hypophyseectomies are going to need hormone replacement for the rest of their lives. All right, now diabetes insipidus is the opposite of SIADH. So they have no ADH and they're going to be dry inside. So the risk factors, it's usually brain surgery or hypophyseectomy, TBI that does it. Could also be due to radiation, and some drugs can trigger it as well. So obviously, if the patient is diuresing, they're going to have large amounts of diluted urine. The specific gravity is going to be low because it's mostly water, the urine. All right, the specific gravity gets very low. They're going to be drinking a lot. They'll be super dehydrated with, dry mucous membrane, so they're going to need a lot of fluid. Decreased BP, and the treatment is desmopressin. With desmopressin, it's a pressin medication. You need to watch out for chest pain, headache, hypertension. Okay, those are the side effects. If you give desmopressin, you expect the urine output to decrease, to come to a more normal level. You also expect the specific gravity to go up, okay, as the urine output decreases. So again, they're going to have polyuria, polydipsia, tachycardia because they are dehydrated with a thready pulse, so +1, hypotension, skin turgor is going to be poor, and remember, we don't do that in older adults. They'll have constipation and weight loss. So we talked about the decreased specific gravity. The labs are going to be high when they have DI because of hemoconcentration. All right. So interventions, you're going to monitor INO. They need daily weights, measure the specific gravity. Monitor the labs. The BUN and creatinine will also be increased early. And after they have some treatment with some medications, you would expect those go back to a normal level. Avoid caffeine because you know that causes diuresis as well. Don't restrict fluids, and they need to be on fall precautions. So desmopressin I talked about. Okay, hyperthyroidism. Okay, you have to know all the signs of hyperthyroidism and hypothyroidism, obviously. Um, so usually, sometimes patients present with hyperthyroidism with cardiac issues. Graves' disease is the autoimmune type of hyperthyroidism, and it's the most common type of hyperthyroidism. We mentioned earlier that they have increased metabolism in a high T3 and T4. Okay, this rhythm is AFib. You can see these QRSs are very narrow. There's no P waves, no discernible P waves, and it's irregular. That's a tip off to AFib. And I will be going over dysrhythmias later in the semester because usually there's some on your proctor, okay? So recognizing cues, everything is up. When people have hyperthyroidism, you have got to reduce environmental stimuli, okay? Because they're already high anxiety, they're sweating, they've lost a lot of weight despite having a ferocious appetite. They have emotional lability, which means their emotions are going to be all over the place. They're very anxious and high strung. They could have amenorrhea. They're going to have tachycardia and tremors. They're intolerant to heat and they have insomnia because their hormones are making them revved up, okay? They're going to be nervous and have tremors and they'll have GI problems, meaning they'll have frequent stools. Now, anybody that has hyperthyroidism is going to be at risk for thyroid storm. So any rise in temperature greater than 1 degrees Fahrenheit may indicate an impending thyroid storm. And many times as a nurse in the hospital, you're going to be taking care of patients with thyroid disorders, and any type of stress can trigger a thyroid storm. So you have to keep this in mind. They might not be in the hospital for hyperthyroidism, but they may have hyperthyroidism, be in the hospital for something else. So you're going to be looking for this. All right, so with hyperthyroidism, again, we talked about the labs you're going to see, ECG, resting heart rate greater than 80 while sleeping could be an indicator, and thyroid scans. They'll have that as a diagnostic tool. All right, so nursing interventions. I talked already about keeping the environment calm and providing rest. They're going to need sedatives. The room needs to be cool because they're heat intolerant and quiet. They need daily weights and eyes and O's, probably going to need to collaborate with a dietitian because despite eating a lot, they're going to have low weight or lost weight. They shouldn't take stimulants. They're going to need antithyroid medications and a beta blocker, especially they're going to go to the ICU if they have a thyroid storm. Monitor temp and vital signs. Now, in terms of medical management, they could have radioactive iodine therapy. Now, this is a form of brachytherapy, so follow all the interventions you learned in Med-Surg 1 about brachytherapy. ATI has recently added some more interventions about brachytherapy for thyroid. Now, they could also have a thyroidectomy. What could happen is they could have some ablation earlier or have, because the thyroid gland is very vascular. So before surgery, sometimes they give them iodine preps to decrease or shrink the thyroid before having surgery. All right. So post-op, if they have a thyroidectomy, remember swelling of the neck could occur, so you're worried about their airway. Put the patient in semi-Fowlers or high Fowlers and support their head. If they complain of a wet neck or they complain of a tight dressing, it could mean they're bleeding. Patients usually have JP drains, so make sure those are to self-suction. Keep the head in neutral position, okay? And you want to help them if they have to move their head. All right, you want to support it if they're turning to their side, etc. Monitor their voice. but discourage them for talking. So like every 2 hours, you're going to say, tell me your name or tell me what you're here for. And you're checking for laryngeal nerve damage. Now you expect them to be hoarse. Their voice is going to be hoarse. But what you're looking for is the inability to talk, because the surgeon may have inadvertently cut the laryngeal nerve. All right, you're going to monitor for hypocalcemia. You're going to make sure there's a trach tray at the bedside and working suction. So in terms of post-op bleeding, because they're losing blood, they're going to have tachycardia, they're going to have restlessness, tight dressing, and a wet neck. All right, hypocalcemia, you have to know these signs and symptoms of Chauveau-Tex and Trousseau's. So make sure you can distinguish them. They could have dysrhythmias, and they could have stridor and muscle spasms. They could also complain about things like numbness and tingling in their fingers or toes, also circumorally, like around their mouth. They complain about that too. So you're going to assess for those signs. You may need to make sure your IVs are always working, your suction is always ready. You're going to give calcium chloride or calcium gluconate if they have dysrhythmias or they have stridor, okay? So you keep the emergency intubation equipment nearby. Trach tray needs to be nearby. Make sure everything's quiet. Okay, thyroid storm. Anything that causes stress can cause a thyroid storm, okay? And then also having contrast media containing iodine can cause it. Aspirin can cause it. Okay, so know how to recognize it. They're going to have a high temp, high heart rate, high BP, anxious and irritable, chest pain, and coma and death. Make sure you always stay with your patient. If you think they're in distress, call for help, reduce environmental stimuli, okay? Then with hypothyroidism, this is due to an underactive thyroid. The autoimmune condition is called Hashimoto's. So we talked about their labs already. And it can also be caused by surgery, like somebody has a thyroidectomy for hyperthyroidism. Now they have hypothyroidism, or they had radiation therapy. And so now they have hypothyroidism instead of hyperthyroidism, and certain drugs can cause it, okay? So everything's going to be low and slow with hypothyroidism. So they're going to be obese, but anorexic, okay? They're going to move slow. They're going to be apathetic. They're going to have constipation. Their skin and hair are going to be very dry. They're going to be tired, lethargic, and have thinning eyebrows. They're going to have intolerance to cold and irritability. They're going to have really low BP. They're going to have bradycardia, no energy, okay? So your nursing interventions. Promote rest by spacing activities. Protect them against the cold. Do not use electric sources of heat. Monitor their temperature. Increase their fluids. You're going to give levothyroxine, and you know this because you guys hit this really well in our activities. You knew when to give it. And monitor for the signs of hyperthyroidism as you're giving thyroid replacement medications. Now, mixed edema coma is a coma that's usually triggered by infection, or some drugs can also trigger it, or exposure to cold, like stress, just like thyroid storm, right? Now with mixed edema, everything is low and slow. So they're going to be hypothermic, they're going to have hypoventilation, they'll have very low blood sugars and very low blood pressure, and they'll be unresponsive. Okay, so maintain the airway, start your aspiration precautions. Remember, don't use electric heat. Investigate like what caused this. Did they have an UTI? Did they have some kind of infection? Is there some kind of stress going on in their life? Daily weights and eyes and nose. All right, and here's a little chart you can compare. Also, in ATI, if you go to ATI Engage, the endocrine lesson, they have these great drag and drops. Highly recommend it. Also, the review book has drag and drops that you can drag the symptoms to, hyperthyroidism or hypothyroidism. Super helpful. And I'm going to post some matrices I made that'll be super helpful for your exam too. Okay, hyperparathyroidism, we talked earlier about this. They're going to have high calciums and low phosphorus. Okay, so students get that mixed up, so burn this in your memory. High calcium. All right, so remember, they're going to have high calcium, so remember bones, stones, groans, thrones, and psychiatric overtones. So calcium is a sedative to the body, okay, for every system except the kidneys, okay? So bones are going to be brittle. If they've had it for a long time, they could have osteoporosis. The kidneys are going to be busy making kidney stones, but also having dilute urine, so they get like a nephrotoxic DI, so they're going to put out a lot of urine. So you need to make sure to protect these kidneys that that patient is getting a lot of fluids, okay? Usually they will order something like normal saline as the IV. You gotta push a lot of fluids into them because of that. Groans are due to constipation, ileus, or abdominal cramping. All right, so remember, if you don't hear bowel sounds or the patient's not passing flatus, you're going to watch that, because if the abdomen gets distended, they might need an NG tube. Thrones means increase into urinary output, but also constipation. Psychiatric overtones, they're going to be very depressed and apathetic. Now, with hypoparathyroidism, it's low calcium, high phosphorus. So, again, just remember your signs and symptoms of hypocalcemia. And in the exam 2 Quizlet, I've got, is this high calcium or low calcium Quizlet? You can do it real quick. And I also believe I have high calcium foods that you're going to need to know. Okay, adrenal gland. We talked about this, knowing which hormones go with which. A pheochromocytoma is a benign tumor that originates usually in the medulla of the adrenal gland, and it secretes catecholamines, which is going to make everything super high in your body. The patient's going to have very high blood pressure, malignant hypertension, throbbing head, red head, complaining of an unbelievable headache, okay? They're going to be diaphoretic because, again, the catecholamines are going to be high in the body, right? That's an activation of the sympathetic nervous system. They're going to have a headache, palpitations with tachycardia. They will have, they'll be very pale except when they get that throbbing headache, okay? Now we're going to go, let me go back up here. Okay, now we're going to talk about Addison's disease. And this is a disease of the adrenal cortex, okay? So patients are going to be low in cortisol, aldosterone, and testosterone, okay? So in Addison's disease, you can remember the signs and symptoms with the mnemonic steroids. So their sugar and sodium are going to be low. They're going to be tired and have muscle weakness, so they're going to be a fall risk, okay? They'll have electrolyte imbalances, so the high potassium and high calcium. So the high potassium, remember, they could have tented T waves on the EKG. So they should probably be on a monitor. Reproductive changes due to low testosterone, so they'll be amenorrheic. Low blood pressure, orthostatic. This is very drastic. So again, they're going to need fall precautions. They have tanned or bronze skin. They're going to have diarrhea and nausea and depression. So remember, hyperkalemia. They're going to have EKG changes. Okay, they're going to have could have slower heart rates and respiratory distress. Okay, to treat it, you remember the K-oxalate, or they could get insulin with dextrose or diuretics. So for hypoglycemia, remember your signs and symptoms of hypoglycemia, but they may have a seizure due to it. Okay. Addison's disease treatments, they're going to need corticosteroids for the rest of their life. If somebody has their kidney out, they have a nephrectomy because the adrenal glands live on top of the kidney. So if they have this, a nephrectomy, chances are that their adrenal gland is taken out at the same time. So you need to watch patients after nephrectomy for adrenal crisis. And you probably know that corticosteroids can need to be tapered, cannot be abruptly stopped because they will go into adrenal crisis. Okay, the diet, they're going to need high protein, high carbs, and be weighed daily. Okay, so again, adrenal crisis. This could happen because of withdrawal of steroids. They could have had a stressful event, and you need to treat the hypoglycemia. And we'll be talking about that in the next lecture. And the drugs that they need is hydrocortisone or fludrocortisone, okay, to replace those hormones they're missing. Cushing's disease is like the opposite of Addison's almost. It's due to too much cortisol. The skin will be fragile. They'll have sleep disturbances and psychosis. They could have psychosis. Truncal obesity with small arms and tachycardia. They have the moon face. They bleed easily, so they have like gastric ulcers, and they have elevated blood pressure, elevated weight, and edema. They have the purple striae. They have high blood sugars. They have a lot of hair on their bodies. They're going to have low potassiums, and they have a buffalo hump. Okay, the labs, low potassium, high sodium, which often leads to hypertension. So that's worrisome. And then hyperglycemia and hypokalemia. Review the signs and symptoms of that. With diabetes, remember there's a difference between type 1 and type 2, and I know you know the difference because you did very well in class on the activities with that. Long-term complications, remember, can be easily remembered with the mnemonic knives, okay? So these happen a little bit later in somebody's journey with diabetes. So like the nephropathy, neuropathy, the eye problems that they have, and the skin problems. They happen a little bit later. So type 1, you know, is prone to ketosis because it's insulin dependent, and it's autoimmune. Type 2 is caused by insulin resistance. In other words, their body still makes insulin. Happens in people over 30 that are obese. If you had a history of gestational diabetes, you're at risk for diabetes type 2. And if you have somebody in your family with diabetes type 2, you are at risk. These people, diabetes type 2, are more prone to hyperglycemic, hyperosmolar state if they get stress in their lives. This is what could happen, okay? Metabolic syndrome can also lend itself to type 2 diabetes, so review the signs and symptoms of metabolic syndrome. And then the assessment, the 3 Ps, I know you already know about that. Having recurrent infections could be a tip that somebody has diabetes. Kussmaul respirations with fruity breath, that could be a tip that somebody has diabetes, and that's a result of compensating for metabolic acidosis. So make sure you can recognize your ABGs as well. Headache and nausea and vomiting, those are other signs and symptoms. So the diagnostic criteria, you have to have 2 of these signs and symptoms on 2 different days, okay? Recall what a casual blood sugar is. That's a blood sugar that's done without regards to meal, and if it's greater than 200, your patient may have diabetes. Review your signs and symptoms of hypoglycemia and hyperglycemia. With DKA and HHS, they have signs of hyperglycememia. So make sure you're looking at that. There is also a great chart in the diabetes text, in the ATI textbook, in the diabetes chapter on the last page, comparing and contrasting DKA with HHS, which is better than my chart. So make sure you look at that. Treatment for hypoglycemia, you need to get 15 to 20 grams of glucose if your patient can swallow. Recheck the glucose in 15 minutes. Make sure you follow up with a protein snack. So like cheese and crackers, or like, you know, chicken and crackers. So something with protein in it, okay? Treatment for hyperglycemia includes regular insulin and only regular insulin IV. You know about the long-term complications of diabetes. Prevention is key, especially when it comes to type 2 diabetes, because that can be managed oftentimes with diet and exercise. So prevention is key. They need tight blood pressure control, tight glycemic control. Everybody should stop smoking. Um, and their urine is going to be checked annually for protein. Okay, everybody needs an annual eye exam. And the hemoglobin A1C is done every 3 months. Diabetic foot care, I know you know it, review it because you guys did fantastic with it on the escape room. All right, exercise guidelines. Glucose needs to be between 80 and 250 before you exercise. Wear proper footwear, closed-toed, closed-heel. Make sure they're really good fitting and not too tight because skin can break down. No exercise if they have ketones present in their urine. So for type 1 diabetics, you are going to tell them that they need to check for ketones if their blood glucose goes over 300. They need to carry medical alert ID, especially if they go like out running by themselves. Check the blood sugar more frequently in the 24 hours after an intense workout. If they're ill, they should notify their provider. They need to take their blood sugar more frequently. They need to take their insulin and their oral meds as ordered because when you are sick, your body is under a lot of stress and your blood sugar is going to go up. I know students get confused about that because they think if they're not eating, they shouldn't take it, but their blood sugar is going to go up despite eating. Test the urine for ketones. I talked about that, and call the provider if they have ketones in their urine. You guys are good with, you guys did well with insulin and also metformin. Remember, if somebody has a test with contrast dye, you have to hold that. Students do usually very well with this. Monitor for the GI issues, so flatulent, diarrhea, vomiting, anorexia, and nausea. All right, and then also watch out for like liver problems. So you're going to need to know the difference between DKA and HHS, okay? So the type of diabetes for DKA is type 1 diabetics usually get DKA. And the onset is fast, usually triggered by some type of stress like an infection. The blood glucose is going to be 300 to 800. So the osmolarity is going to be high, but in HHS, it's even higher. Like the blood sugar is even higher and the osmolarity of the body. So that what that means is that they're very dry. They have dehydration, okay? So with diabetic ketoacidosis, they're going to have acetone breath, ketones, Kussmaul breathing because the body is compensating for metabolic acidosis, okay? They're going to be hungry. They're going to be thirsty. So with HHS, they are also hungry and thirsty. Dry mucous membrane, so both of them will have that because it's dehydration, okay? Treatment is the IV fluids and IV insulin. With DKA, since they're type 1 diabetic, you want to get, the insulin is kind of more important. They're both important, but IV fluids, whereas in HHS, they're very dehydrated, so they need a lot of fluids. So the ABGs are going to show metabolic acidosis, and with HHS, the pH is typically greater than 7.35, so hopefully they don't have any acidosis. So the treatment of DKA and HHS also, because you would give fluids and you would check the BUN and creatinine and the potassium. Insulin is given IV. If they do have peristalsis, they'll get an NG tube. Glucose needs to be checked. They'll be checked hourly. And then when the blood sugar gets to 250, you give fluids with D5. Prior to that, it's usually 0.45% normal saline. Okay, and that's to rehydrate cells because it's hypotonic. Okay, diet is resumed, and then you want to make sure you're keeping track of the ABGs. Okay, nursing care, monitor the vitals Q15, then Q4, monitor for dehydration. They usually have hourly blood sugars to begin with. And then as you're replacing fluid, check for pulmonary edema. Rapid infusion of normal saline first, then 0.5. Then as the blood sugar starts to come down, you can start adding dextrose to the IV fluids. Okay, monitor the potassium. And remember to check the urine output before you give potassium. And that's it.